always known as playing a really critical role in allergy, but it turns out they do a lot more than that. They're a real hub of our physiology, and they house about 200 chemical mediators. And it doesn't just take rolling around with your puppy dog in spring in the hay to set them off. In some people, they can become chronically and inappropriately activated, and that creates a whole multi-system clinical presentation that takes years to build. So by the time your patient's coming to see you, they've probably had every diagnosis under the sun. Now luckily though today we do have with us one of the leading clinicians in the world on this particular topic, Dr. Tania Dempsey. She came across her first patient who had mast cell activation syndrome in 2013, and so has been fastidiously researching it for the last 5 years. And she really is considered a renowned expert on this topic, and she's so passionate about it. I think one of the really amazing things that she's done, she's even managed to convince the leading academic scientist, Lawrence Afrin, to leave academia and come into her practice so that they can help more patients with this particular condition. So please welcome Dr. Tania Dempsey to the stage to tell us more about it.
Thank you. I am really excited to speak on this topic because, for me, when I first discovered mast cell activation syndrome in my first patient about 5 years ago, it was like a light bulb went off for me. And once I identified my first patient, then I identified my second, and so on and so forth. And now 5 years later, I would estimate that 90% of my patients have this syndrome. And so understanding it in my first and learning more and more with each patient has taught me that there is just so much that we don't understand, and so much we can do for those chronically ill, multi-system patients that don't respond to anything else that they should be responding to. These are the patients who react to every little thing you give them. You give them an herb, you give them ibuprofen, you give them one little thing out of nothing, right? And in your mind, thinking, oh, I give this to everybody, vitamin D, they react, and they react. And you think, how am I ever going to help these people? Well, when you start to understand the immune system and you start to understand what's really going on, then it opens up a whole new world for you and those patients. And that's what I want to do today, and I really want to give you, relay my information to you, my knowledge of mast cell activation syndrome, which quite honestly is about this much compared to what I think we need to still learn about. So I wanted to just take a brief moment just to give you my contact information, because a lot of you have come to me and asked how you can reach out to me, and I'm happy to answer emails or respond, so please feel free to have it. I think some of the contact information is on the app as well. So we're going to cover a lot of ground today. I'm going to give you, what I would call mast cell activation syndrome 101. And we're going to move fast, but I think that hopefully you'll get that information that you can bring back to your patients next week. So we're going to talk about mast cells, who they are, what they are, where they're found, and how they work. We're going to look at triggers and activation of mast cells. We're going to look at the many disease manifestations, which quite honestly is mind-blowing now that I understand more about it. All these different diseases that you've attributed to other things, very much related to the mast cell, maybe driven by the mast cell. We're going to look at the role in allergies, because that's sort of how we understood them initially. And we're going to also look at the development of autoimmune disease and how that transpires. And I will discuss a case at the end, looking at my approach to the patient and the different options you have for treatment. So let's start with the basics. Mast cells are white blood cells. Okay, they are produced in the bone marrow, they're released from the bone marrow, and then they go and reside in various tissues and organs all over the body. They are not the white blood cell that lives in your bloodstream, but they're related to one called the basophil. Okay, so what's interesting about mast cells is that they're really found in places where they're in direct contact with the environment, okay, not the bloodstream. They actually synthesize active substances, chemicals, cytokines, all types of mediators that produce a lot of downstream effects. They release granules. There are these packages of these cytokines in response to something that they believe is foreign to it. But they have a lot of other functions in the immune system, and they can actually phagocytose foreign material, bacteria, heavy metals, other blood cells, and they express certain types of enzymes or factors on their cell membrane, which is important because it opens up some options for treatment when we understand the structure of the mast cell. So I want to sort of give you the basics of what the mast cell does in the instance of allergy. So, and that's really, again, how we kind of thought about it for many years. What would happen is you would have this mast cell, and the mast cell has on its surface these, I call them antennas, in a way, and they're really scanning the environment. They're looking for what's wrong, because that's their defense mechanism, right? They're actually our defense mechanism. They're helping us understand the environment. And so they have they have these receptors on their surface, and these receptors are basically waiting to get a signal. In this case, in this diagram or this picture, it's the receptors are IgE receptors. So they're looking at IgE, which is an allergic sort of molecule, and when it binds in a specific receptor, it triggers the mast cell to degranulate, to release the granules, which are often made of histamine, but many others. But in the allergy world, we think of histamine. And the histamine gets released and causes an inflammatory reaction, right? If you think about your patients with allergy, you know that if they're allergic to, let's say, pollen, they will have a histamine reaction. They'll get runny nose and itchy eyes and the like, right? So this is just one way that the mast cell reacts, and only looking at this one mediator, histamine. But there's so much more, and we're going to talk about that. So the interesting thing about the mast cell is that it's a single cell that can behave as an immune cell, an endocrine cell, and even a sensory neuron. All those chemicals that it produces can affect so many different systems. Now, I mentioned histamine is something that is found in the mast cell, but there are over 200 different mediators that are produced by the mast cell. Now, not every mast cell contains all 200. The mast cells are different in different tissues, and even in the same tissue, they will produce different chemicals. So, as you see here, histamine is one, serotonin is another. Right, very interesting, right? It's a neurotransmitter. There are many cytokines that mast cells produce: IL-1 to IL-6, TNF-alpha, interferon gamma, TGF-beta. And so these are some of the cytokines that we've talked about already today. And if you think about inflammation, as we've been talking about, you understand that some of it is being driven by the mast cell. There are enzymes that the mast cell produces as well, and one of the common ones that we talk about is tryptase, which we'll cover a little bit down the line when we talk about testing for mast cell activation. And a very interesting chemical that is worth noting that's also found and produced in the mast cell is heparin. The significance of heparin, if you think about it, heparin is a drug also that we use for blood thinning. But think about your own body making a blood thinner. And think about it making it in an inappropriate way. So we'll talk tomorrow about the link between mast cell activation and polycystic ovarian syndrome and other hormonal issues. And think about women who have, for instance, abnormal vaginal bleeding, uterine bleeding, right? Think about the bleeding that occurs. And what we now are trying to is that some of that is happening because heparin is being released from the mast cells, thinning the blood, causing bleeding. So it's an interesting way of starting to think about your patients, not just looking at the hormonal issue itself, but looking at the immune system and what it's doing. Now, there are many, many other chemicals, and these are few others to note. So when we think about what is going on and what these chemicals do, this is just a very basic view of it. You have an activated mast cell. It releases, in this case, they're showing histamine as one example, lipid mediators as another, and then leading to vascular leaking, bronchoconstriction, intestinal hypermobility and inflammation, and tissue damage. So these are all the things that mast cells can do and more. So again, just to reiterate, mast cells are heterogeneous. They're not all the same, even in one human being, and they're not all the same, obviously, from one person to the other. And that is that's the challenge of treating this disorder, is because we don't really know what a person's mast cells are really like, and why one particular treatment might work for one, and that same treatment will not work for another. And that's actually really the goal of future research, is to understand what the individual's mast cells are really like and what they're releasing and how they can be addressed. Now, mast cells are, again, I just want to clarify that they're found in the tissue, right? And they are really found in areas that are in contact with the environment, because they are our line of defense against foreign things. So, if you think about it, as you're breathing air in, you need your mast cells in the respiratory tract to protect yourself. You have them in the GI tract as you're eating food and potentially, eating pathogens and viruses and bacteria. You need to be protected. So the mast cells are in abundance in the GI tract. They are in the genitourinary tract, and they are in the nervous system, which we're going to really focus on today. And that's a very interesting area that needs to be looked at. Now, there is an overlaying disease called mast cell activation diseases. I want to just be clear on mast cell activation syndrome is one particular subset of the broader definition of diseases. The other thing that's found in that category is something called mastocytosis. Mastocytosis is extraordinarily rare. It's probably less than 1% of patients. I've actually never seen a case of true mastocytosis, although my associate, Dr. Afrin, has, because he's a hematologist and oncologist. But it's a cancer. It's an abnormal growth of mast cells. That's not what we're talking about. We're talking about a condition that all the mast cells, the number of mast cells are actually normal, but it's the activation, the inappropriate activation of the mast cells that's occurring that's making people sick. Now, I like to break it down into three categories as far as mast cell activation syndrome. I call it primary, secondary, and idiopathic. So primary mast cell activation syndrome is really where we identify the mast cell activation as a root cause, the root cause of their condition. And I think that it's very hard, very often, to really patients identify which is really the problem, but there are patients who you will not identify a true trigger, and you'll just address the mast cell issue and get them, and hopefully get them better. There are others who have what I call secondary mast cell activation syndrome, and I would say in my practice, that's probably the predominant thing that I'm seeing. And it's really that it's secondary because it's reacting to a trigger. There's something that is causing it to react, and then it's sort of leading down a path of activation where it can't stop, even if that trigger sometimes is removed. And the triggers are many, and we're going to talk about that. And idiopathic, we actually don't know. Maybe it's a combination of both, and that is, I see that on occasion as well, for sure. So mast cells, in this case, again, they inappropriately and excessively release all these mediators, causing lots of different symptoms. close proximity to neurons. There's no question that they're reacting to each other. And so anxiety and depression is not an uncommon presentation of mast cell activation syndrome. Even in patients who they may not even have what you would consider allergic-like symptoms. Right? That may be your first alert that there's a mast cell situation. In many cases, you're not going to see that. You might just see some of these vague symptoms. So the triggers are many. I couldn't even put them on one slide, but this gives you an overview of what I'm looking at in my practice. And environmental antigens of many kinds are for sure a trigger, both from an allergic perspective and as well as just an other immune reaction. So pollen, food, animals, dust. Pathogens are by far probably one of the biggest triggers that I see in my practice in particular. And there are so many pathogens, and there's so many that we've all acquired over the course of our lifetime. And sometimes we can identify it, and sometimes it's not clear if it's still active. But in many cases, viruses, bacteria, mold, which we're going to talk a lot about, and parasites. And the toxins, of course, I talked yesterday about toxin exposure, and we know that there's a direct interaction between toxins and mast cells. Stress, of course, is a trigger for just about everything, in my opinion. And stress does, the hormones that are released during the stress response interact with the mast cells and can be a trigger. Hormones, we're going to talk about more tomorrow, but there are receptors on mast cells for estrogens and progesterones, and there's no question there's an interaction between those things, and the microbiota and diet, of course. So this is just a picture of mast cells and how they react to viruses in particular, and they can release all these chemicals that we've talked about in response to the virus. Mast cells, we're talking a lot about this process of degranulation where they are exploding and releasing these chemicals, and the chemicals are having a direct effect on the body because it's causing inflammation. But mast cells also present antigen to other immune cells. They're involved in innate and adaptive immunity, so they do a lot. Okay, so let's talk about those specific areas then. So mast cells engage in crosstalk with many cells of both the innate and adaptive immune system. They interact with B cells to affect activation, proliferation, and differentiation. They affect the development of CD4 plus T helper cells. They act as antigen-presenting cells, and they can inhibit or support Treg cell function, which I think is really critical in many of the diseases that we're seeing. The clinical manifestations are many. You will see lots of symptoms that you've attributed and can attribute to other things. But as you start to get the story from the patient, and you start to see that many of these patients have multiple symptoms in multiple systems, then you understand that this may be what is really causing the problem. So in the abdominal area, there's no question, abdominal pain, cramping, diarrhea, constipation, nausea, chest pain, just about anything can present, including malabsorption. Oropharyngeal, we see burning, aphthous ulcers, and sore throats, lots of different things in that system. Coughing, asthma-like symptoms. Asthma alone can be attributed to mast cell dysfunction, and shortness of breath. Ophthalmologic, hepatic, very often elevated liver enzymes can be a sign of mast cell activation in the liver, maybe as a way of responding to toxins that are there, and maybe not. But when you have patients that, and I've learned this over the years, that when I have patients that I give them, it could be an herb, it could be a vitamin, it could be a medication, and their liver enzymes spike, and I don't understand why, because it isn't something that I would consider necessarily liver toxic. Mast cell activation syndrome now is always on my radar, because that may be that the sign that they're reacting to that particular thing that you've given them, and they may not have actually any other systemic symptoms. pressure, hypotension, hypertension, and the neuropsychiatric area is really tremendous. Headaches, migraines, neuropathic pain, anxiety, depression, difficulty with concentration, vertigo, lightheadedness, and even tinnitus. There are many cutaneous manifestations, and hives is one that we often see. Patients often have something called dermatographism, which is if you actually do like a scratch test on their skin, you'll see the hive pop up really pretty quickly, and it'll stay for a little bit. That's a really great, I would call it quick and dirty way of understanding if their mast cells are more reactive. They can have abnormal bleeding, right? I mentioned heparin earlier. So if you have patients who you've checked their normal sort of bleeding factors or clotting factors, and everything sort of seems normal, but they're still having episodes of abnormal bleeding in many ways, you can think about this for sure. Musculoskeletal system is definitely affected. Many of them have bone pain, joint pain, and even osteoporosis and osteopenia are very much associated with this. Interstitial cystitis, which is one of those terms along with fibromyalgia that seems to be sort of vague, and yet there is really good research showing that mast cells are very much involved in the development of interstitial cystitis, fibromyalgia, and the like, and I have a slide on that. And there are many constitutional symptoms. I would say probably the most common symptom that I see in my practice, and I think someone mentioned it yesterday, is fatigue, right? I see constantly that term, and we know that fatigue is caused by many factors, but it's definitely associated with mast cell activation syndrome. This is a great article written by my colleague, Dr. Afrin, who looked at mast cell-associated disease-specific pain syndromes. And if you look at all these, right, it's so clear. How many people see these in your practice? All of them, right? I mean, migraines, right? How many patients come in with migraines? Very, very clear that there's a mast, it's mast cell driven. You just need to identify triggers. Things like interstitial cystitis is on this, and endometriosis, which has been talked about already here, neuropathic pain, and irritable bowel syndrome. So if we think about the mast cell, and I mentioned again, there's so many different chemicals. If I just take one chemical and I just look at histamine, you'll see that a lot of the same things that were found in the slide before are found being driven by histamine alone. Never mind the over 200 other chemicals that the mast cell releases that we don't even understand what it's doing. So, when I think about the disease states, that we just saw, I wanted to add a couple other things that I often see associated with mast cell activation, either being driven by mast cells or causing the issue with mast cells. Lyme disease or tick-borne infections, for sure. Psoriasis, and I wanted to mention dysautonomia, or postural orthostatic tachycardic syndrome, which is really a dysfunction of the autonomic nervous system, causing a lot of dysfunction, a lot of these patients are debilitated beyond anything you've ever seen, and often it is linked to this mast cell activation syndrome, and you have to treat it all. But sometimes understanding the mast cell's role can actually maybe even reverse some of the dysautonomia that we're seeing. So I mentioned earlier that mast cells reside very closely to the nerve fibers, and there's a bidirectional interaction between the mast cells and the nerves and the neurons. So the mast cell can release certain chemicals that the neurons will respond to, something like substance P, which will lead down a pain pathway. Neurotransmitters the same, and the nerves themselves will release chemicals that the mast cells will react to. So I think that this is really a critical piece to understanding those patients who, have these subtle, sometimes not so subtle, neurologic and neuropsychiatric conditions and they've been, mistreated by the medical world, unfortunately, they've been labeled as problem patients, as psychosomatic, etc. And when really they have an immune problem and their body is attacking itself in a way and causing inflammation of the nervous system, and when they're really treated appropriately, you know, their neuropsychiatric symptoms really can just calm down or go away completely. It's really remarkable. So I don't know, and I apologize that I don't know all the tests that are available here in this part of the world. This is a typical workup that I do for mast cell activation syndrome. And I have to imagine that you have a histamine level that you can draw here. That's probably the best thing you can do. You know, using the units we use in the US, we say that anything over 8 nanomoles per liter is positive, is a positive histamine level. What we're doing is we're testing multiple mediators. These are the only mediators that we have available to test. You know, it'd be nice if we had the ability to test the 200 different mediators, but if you find 2 mediators, and that's really what you need, in my opinion and Dr. Afrin's opinion, that 2 mediators will be enough to make a formal diagnosis as long as they also have the clinical features of it. So if you get a histamine level and you are able to get, let's say, 2 down a chromogranin A level, which I do believe is available here, you can you know, make the diagnosis easily. But sometimes it's not so easy. And there are patients that I've had to test multiple times. In fact, the first patient that I identified 5 years ago, it took us actually at least probably 2 or 3 years to actually even find the mediators, because every time we tested her, the levels were normal, even though it was so clear that there's no way she didn't have it. But on the days we would test her, maybe her mast cells were calm, maybe her mast cells were releasing other chemicals and not the ones I was testing for. So it took a while until we could finally identify it. There are urine tests, both random and 24-hour, looking at the metabolites of histamine, looking at prostaglandin D2 and prostaglandin F2 alpha, which are also sort of released from mast cells. The tryptase level I want to mention because traditionally in the medical world, to make a diagnosis of a mast cell condition, most physicians are looking for the tryptase level. Because the tryptase is actually, it's an enzyme, so specific for the mast cell, but it's constitutively expressed on every single mast cell. So many doctors who understood mastocytosis would say you would draw a tryptase level, and if it was elevated above 20, they would meet the criteria potentially for mastocytosis. But the problem is that to get an elevated tryptase, you actually have to have a lot of mast cells. But I mentioned earlier that mast cell activation syndrome is actually not an increase in the number of mast cells. It's actually that the mast cells are inappropriately releasing their chemicals, not that there's more of them. And so the problem is that if you rely on a tryptase level and it's normal, it doesn't mean that they don't have mast cell activation syndrome. It just means that they don't have mastocytosis. They don't have cancer of the mast cell. So I'm cautious with that. I always test it, and you should, because there are cases, of course, that you're going to identify a problem, potentially, but I just don't want you to rely on it because the literature is very mixed on this particular marker. So I want to, again, just go back to this notion of the mast cell and its effects on the nervous system, and there's some really interesting literature out there looking at its link to things like multiple sclerosis and experimental autoimmune encephalomyelitis. We also have this really great article written by my colleague Dr. Afrin, also looking at the underappreciated cause of neurologic and psychiatric symptoms being caused by mast cell. That's a great study if you treat patients like this. It's really a mind-opening. So when I test for triggers, I look at a lot of things, and I'm giving you a sense of what I'm doing in my practice, but not every single patient am I going to test every single thing, right? You're going to get a good clinical history, and you're going to get that history starting from preconception, if they can provide that information, all the way to the present day. And when you do that, you're going to start to see patterns. You're going to see patterns of reactions. You're going to see patterns of triggers that they've had in their life. And if you ask the right questions, you're not going to always need to test all of this. But there are definitely things that I can do and want to do at times to look at the toxins. I do, because I have an interest in infectious diseases, I do a lot of testing for infections, both antibody testing as well as PCR testing, trying to identify if there really is an active infection happening. And in many cases, there isn't true active infection. However, past infection was enough to get the ball rolling. And so I do often, at least in my patient population, because of where I practice in the world and we're really in an endemic area for tick-borne diseases, that's always on my list. And that pretty much I do test most of my patients with. Mold is a really big problem, and that's something that is probably for another conference, but there's no question that mold and the toxins produced by mold and the bacteria found in water-damaged buildings as well as their endotoxins that they release are really toxic to us on many levels and toxic to the mast cell. So it's not uncommon for me to hear from patients that they lived in a certain place and they moved, and when they moved to a new place, they started feeling very symptomatic. They couldn't breathe, they were fatigued, they started sort of declining. And I always then think about what is it about that place that they just moved to that caused that, and very often it's something in the environment such as mold. And so there are a bunch of tests that I do, and I apologize because I don't know how much of this is available here. I imagine some of it is, and I think it's very, very helpful to look at that. And we've talked about the adrenal glands quite a bit, and that will be part of the story. And the psychosocial piece, okay, not just the history chronologically, but also understanding. Yesterday we talked about trauma and abuse and things like that. We have to look at that because there's no question that there's a higher rate of mast cell activation syndrome in patients who've had some kind of trauma or stressor in their life. The microbiota is very much involved in many things, as I mentioned yesterday, and there are a number of ways you can look at it. You know, I just think even asking whether the patient was breastfed or bottle-fed can give you a little bit of insight into their microbiota, their history of antibiotic use, and sometimes you can do some testing. Ubiome is an interesting, it's one company, but it's an interesting test, you know, that's identifying all the various bacteria in the gut. And this is a study that actually looked at mast cell activation disease and the microbiota directly. So again, there is data to support, you know, what we're talking about. You know, I do often test for IgE-mediated allergic reactions. They're worth doing, but many of these patients will have negative IgE testing, negative allergy skin testing. These are the patients that many of them will have, let's say, symptoms that someone has thought of allergy in, and they get tested, and of course they're told they're not allergic, but they know that they react to very specific things at certain times of the year or certain foods. And it's worth testing, but often not doesn't come to fruition. And it's because they have an inappropriate activation of their mast cell. I want to spend a moment, I think there are some of you here who do prescribe medication. You know, the way I think about treatment of mast cell is I want as many tools in my toolbox as I can get. And if I eliminate, you know, some set because I think it's, you know, medication is bad, then I'm not doing the patient, any service. So I really want to have all those options and show you there are times when the pharmacologic agents are necessary and important, especially in dampening down the reaction that they're having. So we use things like antihistamines. And the media has done a little bit of a disservice to patients in the area of antihistamines. There was a study that came out recently that said that certain antihistamines, maybe the more sedating antihistamines like Benadryl, diphenhydramine, which is Benadryl, may cause dementia or cognitive issues. They're looking at patients maybe who took it for many, many years. The problem is that some of these patients need antihistamines. It calms the reaction down very, very quickly. Some of the newer agents, the loratadines, fexofenadines, cetirizines, are maybe less anticholinergic, and so maybe they have less of an effect. But I think that they're important, and we often combine them with the other type of antihistamines called H2 blockers. Those are the ones that are used for the gut. Now, you can say, well, I don't love to use drugs like that on the gut because of the damage on the microbiota and absorption and things like that. But again, sometimes you need it because the patient is just, dealing with their microbiota while they're reacting and they can't get out of their house. It's not helping them. So we sometimes, often combine an H1 and an H2 blocker, and we give them together, and we calm the situation down. And there are many other things that we use, all the way down to one of my favorites is low-dose naltrexone. We're going to now go into a case, and I'll finish up with the case and talk about the natural approach to this patient, both pharmacologic and natural, so you understand my view. This was a poster that I did on this case. So this was a 15-year-old patient who presented with severe depression, anxiety, fatigue, and headaches. Okay, that's not an uncommon presentation for many of the patients that I see. What was really interesting is that up until 6 months ago, she was actually, a top student, getting good grades, captain of her track team, living life as a 15-year-old. And then over the last 6 months, she lost her ability to concentrate. She had difficulty finding words. And what was really interesting is in seeing her, she could barely even talk. The story was actually given by the parents. She sat huddled up in the corner and could barely even articulate, almost catatonic, not, but sort of just not able to give us what was going on. She had a really interesting history of an eating disorder that started 5 years earlier, but they did all kinds of therapy and seeing nutritionists, and nothing worked, but it spontaneously resolved after 2 years. And so she had been fine for almost 3 years, and the eating disorder recurred at the exact same time all these other symptoms started. So that was a clue. There was something already going on 5 years earlier. And she did complain of itching skin. And that's not an uncommon mast cell complaint. And the other important piece of information that I found was that there was water damage in the home about a year prior. But it was sort of, dealt with, and there was some remediation that was done, and they didn't really think it was important. I always ask the question about the house, if there's water damage, if there's been a leak, even the slightest thing that you wouldn't think would be significant, could be to someone like this. So her family history was significant in that her sister, who was a year younger, also had a lot of depression and some learning disabilities, and also seemed to be worse over the last couple of years. And her mother had a very similar story and complained of fibromyalgia and irritable bowel syndrome. So I take that and I say, okay, I'm getting a flavor of a family history, which is not uncommon in these patients, that the mother herself might have something similar. So as I mentioned, she really had flat affect, very poor eye contact. And again, what was surprising is that this girl 6 months earlier was running track and getting good grades and participating in class. When she sat in my office, I couldn't even imagine her participating or doing anything that I would expect. So it was really quite remarkable. She had, what I mentioned earlier, that dermatographism. So, we scratched her skin and we saw the wheal come out. She was a little bit hirsute. And definitely had that sort of a little bit more body hair and facial hair. And she had a mild thyroid enlargement without obvious nodules. We checked a number of labs and we found low B12, low folic acid. These are low in my book and by our standards, low vitamin D and low calcium. She actually tested positive for the HLA-DQ8 gene, which is really an autoimmune gene that's linked to celiac. So I do that even though I didn't diagnose her with celiac, and she doesn't have celiac. Understanding her genetic potential for autoimmune disease was important. And I might suggest, or I should say I will suggest, and have suggested that patients like this be gluten-free and sort of assume that they are celiac. And there obviously is controversy to that, but I think that's important. She had one copy of that MTHFR gene, C677T, and she had low testosterone, even though I was expecting it to be high, given her hirsutism. So again, I knew something was off. I did my tick-borne disease panel, and she did not have Lyme disease, but she did. And so this is like a take-home message that we often talk about the patients going, oh, they don't have Lyme, or there isn't Lyme here. But she tested positive for 4 other infections that are insect-borne. She tested and actually fish positive for Babesia, meaning they found the RNA of the Babesia in her bloodstream, which to me means active infection. And she tested for antibodies to 2 strains of Babesia, Bartonella Hensley, which is a very common insect-borne infection, West Nile virus, which we know is transmitted by mosquitoes, and tularemia, which is another tick-borne infection. So, antibodies and even evidence of some active infection, no question was playing some role. And then we started doing her mast cell workup. So her histamine levels, I mentioned earlier, greater than 8 is abnormal. She was 12. Her chromogranin A level in the lab we used was a 0 to 15 range, and she was 20. So I had my 2 positives. I had a history, and I knew that we're dealing with a mast cell activation issue. She also had a low positive for anti-nuclear antibody. So again, I was already suspicious of the autoimmunity because she had an autoimmune gene, but she was showing some signs. And she had a really significantly positive Cunningham panel, which is a test for basically autoneuronal antibodies. So these are antibodies directed against the nervous system. And she had sky-high levels of anti-dopamine receptor antibodies, anti-tubulin antibodies. And so basically what we were looking at is a body attacking her nervous system, maybe from all these triggers that we talked about, probably, and leading down the path of the neuropsychiatric symptoms we were seeing. Eating disorder, no question associated with these antibodies, anxiety, depression, etc. And there's good research supporting the role of mast cells in even the development of autism. So, I think I have running out of time, so I'm going to skip through some of these a little bit because I want to get to the treatment. So, what we did initially, right off the bat, and even sometimes I'll do this with patients, I wanted to say sometimes, I always, with patients when I'm seeing them, start them on some regimen even before I have data. There's very little downside to putting patients on dietary changes, right? So I knew she needed to be gluten-free, which is very resistant to that. I suggested a low histamine diet, which can be very difficult for patients, but worth trying. Anything to sort of calm down the histamine in the body. Diamine oxidase is an enzyme that we have naturally in our body, but many of these patients don't have enough. And this is an enzyme that breaks down histamine in the gut. And so sometimes you can just give a supplement to break down the histamine. My goal was really, I needed to stabilize those mast cells, reduce histamine, reduce inflammation, and address her methylation defects, right? So that's nothing, right? I can do it. It's a lot. It was a lot. It was a long process. This is just a quick overview of the foods that are often considered high in histamine and foods that liberate histamine. This is not complete, and I will tell you that my patients often can tolerate 1 or 2 of the foods high in histamine, but not other foods that you would think would be fine. So again, you always have to work with the patient individually, but just to give you an idea. And then I'd like to talk about treatment and some simple things that I can look at and start with. Quercetin is one of them. Quercetin is found in lots of different vegetables and fruits, apples, green tea, onions, nuts, things like that, but you often can't get enough. Quercetin is an anti-inflammatory, it's an antihistamine. So again, it could be like let's say the patient doesn't want to use an antihistamine pharmacologically, you can try quercetin. I do want to mention, based on Dr. Gottfried's talk yesterday, that it's an inhibitor of that enzyme she mentioned, COMT, or catechol-methyltransferase. And so people who have very, very slow enzymes, COMT enzymes, you give them quercetin and you slow that enzyme down even more, they're going to wind up with lots of dopamine and really not feel well and get more anxious and depressed. So sometimes it is worth testing this polymorphism to see if quercetin is safe to use. Quercetin was studied against cromolyn, which is a pharmaceutical that we often use for this, and was found to be maybe more effective on some levels. So I love studies like that, drug versus natural. And this is just a little information about the COMT. These are some herbs and natural products that you can eat. That's worth noting. Watercress has mast cell stabilizing effects and antihistamine effects. Moringa, capers, believe it or not. Ginger, which is one of my favorite antihistamines and mast cell stabilizers. And pea sprouts are really the only plant-based way of getting this diamine oxidase that breaks down the histamine. Olive extract as well. So I'm continuing her treatment, and I know now that I have to address some of these infections. I think those are very, very critical in her condition. And so we looked at herbs, we looked at antimicrobials, both natural and pharmaceutical, homeopathy. We didn't do LDA, but it was worth mentioning if some of you are doing it or interested in it. So I added berberine because berberine is actually an antimicrobial agent, but it also does something really interesting, and it binds heparin. So if this is a patient that you think has a bleeding issue, and maybe heparin production from mast cells, berberine is a really great tool. And there's some good research on berberine as well. Actually, a lot of research in many different realms. Angiographis is a really popular one that I really love. This herb, I don't know if many of you use it, but it does so many different things, but it decreases some of those interleukins and cytokines that are released from the mast cell. So this can be very, very helpful, but it's also antimicrobial, and I'll use it in my patients with infection. So again, this is the slide that I had previous, which was looking at the pharmacologic. And again, just to remind you that there are lots of options, and you'll see on the list, I want to mention benzodiazepines. Benzodiazepines are those drugs that we don't love our patients being on, Xanax, Klonopin, Valium, and all that, but I will tell you it is a very potent mast cell stabilizing agent. And if you have a patient who comes to you and has a chronic history of these, and you're really having trouble getting them off, that's one of the clues that they may in fact have mast cell activation syndrome. They're actually medicating themselves, and often it's one of the few things that work. So I'm certainly not advocating its widespread use, but I think sometimes it's very helpful, and sometimes it gives you a clue of what's going on. So in this patient, she was definitely getting better, and she was still missing a lot of school. She was going more, but she was missing. And so we still had to keep working. So we added some antibiotics, targeted at the things that I knew that I needed to treat, antifungals, a bunch of things. And the problem was that she was still not functioning the way she needed to. So I always go back, what am I missing? What are the triggers that I haven't identified? And we went back to this water damage thing. And I always do that with patients. Are you sure that the place was remediated? Are you sure there's no smell? Are you sure? And finally the parents were like, yeah, you know what? Maybe there is something going on. So we did her testing. I tested her for mycotoxins, or the toxins released from mold, and we tested the home. And there was no question that there was an overlap. What she had in her system was found in her home. And so we were concerned, and she had exposure to Stachybotrys in particular, which is black mold, as well as aspergillus. And the thing about mold, the little pearl that I want to tell you about is fungus. Many of the funguses have hyphae, right? Those are those long legs that you sometimes see in those pictures of yeast. The hyphae themselves actually can reach reach out and touch the mast cells. In a way, they explode, sort of like popping a balloon, right? So you imagine the mold doing that in the body. In addition, the mast cells themselves don't like yeast or things like microbes, and so it's reacting on one level, and the yeast is actually physically causing them to release, and so you're in this really vicious cycle, and patients can be very, very ill. So we moved her out of the house. It was took the parents a lot to really come to the conclusion that they had to give it a try. We didn't know what else to do to get her to where she needed to be. 1 month out of the house, all her mast cell levels go down, her grades pick up, she starts becoming more social. She sat in my office, making eye contact with me and describing, how she was feeling, right? That was a different child. But there was still fatigue, and so okay, what are we missing? Let's keep going. And I addressed some of the exposures to the biotoxins, and we did some other dietary changes, and the improvement just continued and continued to get better. She applied to college. She got into her first choice. She went to college. She just finished her first year in college. I just saw her 2 weeks ago in the office for a follow-up. Amazing, amazing transformation. She knows she has mast cell activation syndrome. She knows that if she works too hard, doesn't get enough sleep, parties too much, doesn't eat right, etc., she may flare. She may flare, and I had a few calls during the year with, oh my gosh, are we going down the wrong path again? And we just figured it out, and we just got her back and made some adjustments in her regimen, and she got there. So these patients are not necessarily cured. They're at risk for recurrence. But now if you know what works for them, maybe it's a little easier each time. So I want to conclude with the idea that mast cell activation syndrome is increasing in prevalence in the chronically ill patients. Okay, we have data. We have more and more data that probably 17 to 20% of the population have this, and I think the numbers are going to continue to go up. I believe that mast cell activation syndrome is the root cause of the manifestations of chronic disease, and diagnosing mast cell activation syndrome and hunting for those underlying causes and triggers and treating it can greatly improve the quality of life of these patients who have suffered sometimes for 40 or more years. So I thank you all for listening, and I look